It's your first day as an intern on your general surgery rotation. You're happy. You're telling your friends, you're telling your parents how excited you are. You commence your first day in the surgical ICU. Everybody's pumped. You say hi to the nurses. You're happy, enjoying yourself. Hey, it's gonna be fun. You're rounding on your patients and you go to the patient's bedside. You got sign out. This patient is someone who had a fall with a high spinal injury. You're concerned that they may have diaphragmatic weakness due to the level of the spinal injury. See, 3, 4, 5, keep the diaphragm alive, they say. They say, okay, you got this. You're by the bedside, and off the bat, the first thing the patient says to you is, I cannot breathe. You look at the patient, you're examining them, you're wondering to yourself, man, wow, you're concerned. This could be diaphragmatic weakness. So, you stay by the patient's bedside because you trying to make sure that everything is okay. You look on the monitor, you check the saturations 100%. You look at the respiratory rate, it's 20. You're like, oh, that's not bad. But something is atypical about this patient's breathing. You look on the chest, you see that the rise and fall of the chest isn't that significant. In fact, the right side of the chest does not move as much as the left side. You listen, there's decreased breath sounds on the right, but good air entry on the left. You look on the patient's abdomen, you notice there's abdominal breathing. You're like, something is wrong here. In the quint of an eye, the patient stops breathing and his eyes starts to roll back in his head. Your heart is pumping. Everybody is nervous now. You're wondering, man, is this gonna be a code? You look at the monitor, there's no pulses. You call the code. Nurses jumping on the chest. You are there mobilizing staff. You want everybody to act quickly because in the split of a second, this person could die. Every minute is time lost, and every minute adds up to mortality. Everybody's acting quickly. Epinephrine is going through the veins. You're getting the anesthesiologist to intubate this patient. Bam! In less than 2 minutes, patient's intubated, patient's receiving good oxygenation on the monitor, and you get a chest x-ray. Lo and behold, the entire right lower lobe is collapsed. You're thinking to yourself, what could be the cause? You analyze the x-ray film. You see a whiteout from mid to lower side of the right lung. You're thinking to yourself, is this pleural effusion? Is this a collapsed lung? You analyze the rib spaces. You notice that the rib spaces are more contracted, more close together. You check the mediastinum and you see, oh, the mediastinum is actually deviating to the side of the whiteout. If that's the case, you know that there's loss of space in that right side of the lung field, consistent with a collapse. You check the radiology report and it's saying probably pleural effusion, but if you went ahead and put a chest tube there, you'd have made the wrong decision. Important that you analyze the films for yourself. Again, in that moment, what's the next step? You do a bedside bronchoscope and you notice copious amounts of mucus in the right main stem, in the right lower segment of the lung. You suck it out, keep the patient intubated, patient saturation improved. The immediate threat to life has been abated. Be careful. Listen to your patients. They'll tell you what's wrong. Thanks for listening.